had the stat with, you guys know much more than we do. So this is a working kind of session of trying to actually look at the research, look at what is out there, and try to come up in groups with kind of what a proposal plan after we kind of figure out what the problems are and why kind of the current state is as it is. So we wanted to start by introducing Logan. She's awesome. And second, by watching the first 5 minutes of this video.
Okay. Is that gonna work? We might have to plug it. It just worked. It's never happened.
No, it's not just.
Okay, I didn't think so. That would be unprecedented. Okay.
So this, before we jump into the video, this woman is a doctor in SF. She primarily treats Silicon Valley entrepreneurs. So I love the first 5 minutes of her video. Then she gets into all this stuff that like basically only millionaires can do. But
the first 5 minutes is the stuff the rest of us can do.
Are like a very good overview, I think, of the problem with chronic disease, obesity, etc. in the U.S.
Hi everyone. I want to take you on a trip to Peoria, Illinois. It's a microcosm of America. There's a saying, if it plays in Peoria, because it was such a proven test market. When my dad was a kid, he ate at the McDonald's down the street so often, he had a charge account there. When I was a kid growing up in Peoria, I decided I wanted to be a doctor. So I went to medical school at the University of Illinois, and in my clinical rotations in Peoria, the same doctor who delivered me taught me how to perform a C-section. I thought the job of a physician would be getting to figure out really cool cases of interesting pathology. But instead, when I was on rounds at the hospital, I noticed something troubling. Almost every patient that I saw had some kind of chronic disease. It was like there was a zombie apocalypse happening, except no one was running around screaming. Instead, there was a quiet acceptance of what was happening, and it looked like this. Sorry, is that a little too much? It occurred to me there was a common thread behind all of this chronic disease that I was seeing. A single factor was increasing the risk of death, and it wasn't high blood pressure, high cholesterol, or elevated blood glucose. No, it's our food. This is a typical middle-class American family living in Peoria, and this is what they eat in a week. In fact, the top 3 sources of calories in the American diet are refined flour-based desserts, followed by bread and soft drinks. And it's not just Peoria. A recent worldwide study of 190 countries found that even though there are more healthy options available than ever before, the world is mostly hungry for junk food. And according to the journalist Michael Moss, packaged processed foods are engineered by companies for optimal palatability by appealing to the selective taste receptors of salt, sugar, and fat. This magical combination causes a jolt of endorphins and dopamine in the brain, which gives us the feeling of reward and desire to continue eating. But the problem with this is that studies have shown that these nutritionally vacant, highly processed foods can trigger addictive behaviors and compulsive overeating. I would argue that junk food is now the most readily available and widely abused drug in the world. But somehow we bought into this idea that we can just take pills to fix ourselves, to lower our cholesterol and blood sugar. But is modern medicine really solving the problem? Take statins. These drugs are commonly prescribed to lower cholesterol, but they also increase the risk of developing type 2 diabetes, muscle and liver damage. And in 2012, the FDA slapped a black box warning on statins, saying they could raise blood glucose levels in people at risk for type 2 diabetes. In 2014, the Statin Diabetes Safety Task Force stated that although statins can lower the relative risk of heart attack, stroke, and death by 25%, they increase diabetes by a relative risk of 12% compared to placebo or usual treatment. So are people trading a heart attack for diabetes? Many people believe that diabetes is merely an annoyance and can be easily treated with medicine. But the United Kingdom Prospective Diabetes Study clearly showed that after 6 years of diabetes, oral medications eventually fail in 44% of people. And insulin injections are almost inevitable. If our solutions were working, we wouldn't be seeing metabolic disease rates continue to climb. Between 1980 and 2013, global diabetes prevalence skyrocketed from 108 to 382 million people. In 2013, it caused 5.1 million deaths and was responsible for 11% of global healthcare spending. People are losing their limbs and their eyesight and their kidney function, and every 6 seconds, someone dies from this disease. But somehow, because it develops slowly, it's less frightening than Ebola or HIV. To quote the editors of the esteemed medical journal, The Lancet, the fact that type 2 diabetes, a largely preventable disorder, has reached epidemic proportion is a public health humiliation. Here's the thing you may not have guessed. Did you know that 80% of our chronic disease burden is totally preventable? For example, one example of a culinary medicine prescription.
So that's where she starts to go into solutions, but we just wanted to set the stage. We'll go into a little bit more detail on the statistics, but set the stage of the scale of the problem and the fact that pharma basically is not working, so we need to look at other solutions.
Alright, so 1 in 2 adults in the US has chronic disease and 1 in 4 has 2 or more. My question to you now is, what's the #1 most obese nation in the world? Where? No, it's Kuwait. #2 is the US.
Mexico's the highest problem diabetes. It's the highest. It's #1 in diabetes.
So this is why this is a great team, right?
Yeah. Wait, it's really #1?
Yeah, we saw that in a case study last week. It was 79% of the population of Kuwait is overweight or obese. Hence. So just a little bit more facts to set the stage.
Put that on Logan instead.
9.4% of the population has diabetes, and it's over 100 million people are pre-diabetic. You have 600,000 that are being treated for end-stage renal disease, which costs an estimated $90,000 per patient per year. And when you look at the rest of it, 86% of American healthcare costs is spent on chronic disease. So this sets the stage of how robust this problem is, and it touches everybody and kind of every aspect of our lives and kind of costs too. Okay.
Just one more thing on that. So most chronic diseases are caused by just a few risk factors. One is obviously poor nutrition, and those chronic diseases are very unevenly distributed in the US according to socioeconomic status, race, and all of these things that are not new to you guys, but just want to highlight that. So to give a little background on how we landed on food as medicine, originally we proposed to Professor Fernald that we were going to look at what the most effective nutrition intervention for chronic disease was, and she was like, that's way too broad. Basically, because this is such a costly problem, we wanted to look at like, okay, is it digital health apps? Is it an employee wellness program? Is it intensive counseling? What we found through the literature is that there's pretty limited evidence on each of those things, and that most studies we were able to find compare different diets. So they say like, if we put someone who just got diagnosed with diabetes on a low carb diet, how do their results differ from someone who's on a moderate carb diet? There's a good amount of evidence on that, not quite as much on methodology. I kind of struggle with that because there's also a lot of evidence that diets don't really work. So you can put someone on this low carb diet, their adherence is probably going to be pretty low, and especially after the study ends, they're probably not going to be able to continue those habits. So we have some quotes here about the need for better results in this area, but there is one thing that is an idea that's been around for a while, but is starting to gain more traction, and we're starting to hear a little bit more about, and that is food as medicine. So this first article is one that I shared with you guys. Hopefully you're able to take a look at it. It's kind of an overview of what's being done in California right now for both cancer and some of these metabolic diseases like diabetes. And then we also just put a couple more articles up here from different sources that are starting to talk about this. It's starting to get more traction with providers and payers, and the evidence thus far is pretty promising, which is cool. So what is food as medicine? There are many different models. The way that I'm going to treat it, and I'm sure all of you have slightly different definitions, is providing medically tailored meals directly to patients. So this would not be something like ESF, which is providing vouchers for fruits and vegetables. I'm really defining this as you're getting all of your meals medically tailored for you if you have diabetes or you have high blood pressure or congestive heart failure or something like that. Each of these models has, I think this is something that's super cool, each of these models has tried to get at the problem through a different stakeholder. So God's Love We Deliver operates in New York City. It started as a solution for HIV/AIDS, as did Project Open Hand, and those two work directly with patients. So you can go to their website, you can say, I want to become a client. They have certain criteria that you have to meet to be eligible, and then they'll provide meals to you. So it's like a traditional kind of nonprofit model that's going directly to patients. Community Servings operates in Boston, and they've actually been able to work with payers. So they work directly with insurance companies to make this a covered benefit for patients. Manna is in Philadelphia, and that one works with a health system called Geisinger, which you guys might be familiar with. It's kind of like a Kaiser model where they do full capitation, and Manna provides meals to some patients who are part of that health system. And then lastly, Wholesome Wave is more of an activist organization. Like, they're aggregating a lot of efforts that are already going on in the space, but they have chosen to work primarily with providers. So they'll go to a PCP and they'll say, here's an idea that could be really effective for your patient population, and try to get this going through that lens.
So, this is open to you guys, and I'm going to put this on the board. This is going to help us frame the final discussion. So, who do you think the best stakeholders to work with on this issue would be? And start talking.
So we have all these examples, like basically everything has been tried, but if you guys just have like a gut feeling about who is best to work with, kind of pros and cons of each.
I think at the center is the patients themselves, who have whatever disease or interest.
Yeah.
Decision.
Okay. Yeah.
And dietitians.
Mm-hmm.
Chefs and restaurants.
Ooh, say more about that.
So if you have a partnership with them or you have buy-in from them, some sort of like give and take, then you can get really high quality meals provided. So it's not like meals that are medically tailored, but maybe like they don't taste very good, or because they're not made by someone who knows what they're doing.
Yeah, it's not what you think of when you think of hospital food. It's a little more than that. Vanessa?
Farm companies. I think we have to have a discussion with them and see how they would be impacted by the whole food as medicine.
Do you mean farms or like
The
pharma?
pharmaceutical companies.
Oh, okay.
Oh, okay.
I can also see partnership with farms. Like, that could go either way.
Okay, why pharma?
Because they could be impacted by this.
Yeah.
If this turns out to be an effective way of reducing chronic disease, then
Yeah, Pfizer has to say goodbye to
Yeah,
Lipitor, right?
Yeah.
Yeah.
But what would be their incentive to work with us to do such?
You just wanna give them a heads up.
yeah, I'm not sure. I think it's something that they would need to be involved in.
I mean, you could say like, hey, this is really growing. We know you have a very robust R&D like pipeline. Can we like find some way to work together on that? You know. Yeah. Insurance.
Oh yeah.
We'll talk a lot more about that, but the insurer is ultimately the one who bears the cost of chronic disease, right? So that's a powerful one.
Policymakers and making sure that these programs are accessible to all groups, not just those who can afford them.
Wherever people buy their food, grocery stores, farmers markets, farms.
Yeah, we have one, the article, the second article, which I didn't share, but it's the NPR article. It sets the stage by saying, it's way back apparently. There are certain providers who will go stand in a grocery store and try to help advise people on what they should buy. Laura?
Nonprofits like food banks. The food bank here in Alameda County just tested medically tailored meals for diabetic patients through their food pantries.
So, yeah.
I had heard of a program that they partnered with a school, and they did a nutrition training for adolescents and high schoolers, and so it could be schools could partner with this, and they could learn nutrition and serve the meals to the chronically ill.
Yeah, for sure.
People are making meals.
Yeah. Or do you mean like Munchery or somebody who's already delivering food? All of them, that whole space.
Advocacy organizations like AARP is a big proponent of this, and then they can help you connect with insurers to sway what they see.
Have like a potential competitor, maybe a stakeholder, but I don't know the name of this, what I would call this group, but you know, those folks, those companies who are already touting questionably backed, like superfood or new like products, you know, like magic pill or like whatever.
Like the nutraceutical type space?
Yeah,
Or
exactly,
the,
like nutraceutical.
what's that space called that you just told me about?
Oh, nutrigenomics.
Nutrigenomics,
Yeah.
that kind of like personalized food.
Right, exactly, where it's like, I don't know, this is really probably not scientifically backed, there could be competitors, but at the same time, we kind of have overlapping interests where we're trying to move away from pharmaceuticals into more natural.
It's true though, you get the feeling that the pharmaceuticals would jump on this and say, oh, we can make a bar, or we can make a product, or we can make a prefab thing. Right, in that space. There was somebody else.
So, community members or health promoters that can make these programs culturally sensitive and let people know in these communities that are the most affected by them that they're there to use.
Okay.
Oh, sorry. No, go ahead.
No, go ahead.
I just had to, like, kind of like along the lines of people are saying, but social workers who do like home health care, because if they refer to something like Meals on Wheels, they can also refer to something like this. And then also like along the lines of nonprofits, like there's some nonprofits that do kind of like job skills training for women who are like escaping abusive situations. So it could be, you know, like cooking job training to prepare them for working in a restaurant, and this could be a way that they make sure to like gain a profit for what they're doing.
Yeah. That double aim.
Like a Rubicon.
More than we thought of.
Okay, so keep these in mind because at the end we'll put all of the pieces of this together. Okay, so initial study results. Obviously, I cherry picked the best ones, but the results are really powerful. So the first journal article that I posted is meal delivery programs reduce the use of costly healthcare in dual eligible Medicare and Medicaid beneficiaries. This was recently published in Health Affairs. And so what they did is they took a group of people, it was with Community Servings actually in Boston. So they took a group of people and they gave them all of their meals for this 19-month period. Then they compared them with a similar group that did not receive meals. And the huge caveat here is it's not like they took a group and randomly assigned you're going to get meals, you're not. They had the group that received meals and then they tried to make the second group as similar as possible. So there is a chance, like I think a lot of you guys are in FEs right now. This is a paper critique, like so that's a huge caveat, and it's not technically RCT. But
They did a pretty good job matching.
yes, yeah, they have
So
this.
that
Like,
they knew that was a problem. They-
so results: 50% fewer hospitalizations and 1.5 fewer ER visits for the group that got the meals. And the project, I'll just share this, the project that I worked on this summer was all around how to reduce hospitalizations in the commercial insurance market. And I found out that the average hospitalization costs Cigna $36,000 for one patient to go to the hospital for an average of like 4 days at a time. And also the average dialysis patient goes to the hospital twice a year. So if you can reduce that by 50%, you're saving Cigna $36,000 per patient per year. And I think that provides a really powerful incentive for them to say, okay, yeah, we are going to cover food as a benefit for certain subsets of our population. And then second one, which I also posted, this one was recommended. So, sorry, go ahead.
So yes, insurers pay for it, but ultimately we pay through it through like either employer insurance or private insurance, like in some way. So I think ultimately it comes back to the people. So I guess how, like, if you were referencing like making the like incentives for the health insurance. I guess how would you address that when they can just relay those costs back onto the people? Like how do you then incentivize the
that's a great
actual
question.
insurance?
So you're looking at it from a systems perspective. So if you reduce the cost on the insurer, then you reduce it and improve the health of the population, then there's a total reduction of costs on the system. So inevitably the premiums will go down if that's a cycle. So you got to start with the payers because they're going to pay for this as medicine or as a prescription. And if they are not incentivized to see that cost differential, then this is going to be a hypothetical that we're going to try to hope catches on. And that's why in starting with insurers is a very important part. Payers, somebody needs to pay for this. This as diseases is mostly in low socioeconomic communities. So if you look at it, if you're telling them to eat, there's reasons why they can't eat healthy out of their behavioral means. It's economic, it's societal. So unless you pay for that, then it's not gonna catch on. That answer?
Yeah, I guess I'm just like referring to like what ways, and this is a question for everyone, like what ways to incentivize insurers, because I know you have to start with insurers, but like they can just relay those costs onto the people that pay that.
So the only thing I'd add is that, like a dialysis patient, for example, obviously that's a small subset, but that is a patient that is so expensive that Cigna loses money on them. Like the rates they would have to charge to cover how much a patient with ESRD costs them are way higher than they charge today. If they could dump all dialysis patients off of their books, they would make a lot more money, but because they have them on their books, like they are their patients, they're looking at ways to make them as cheap as possible. Does that make sense? Like,
and they're looking for there's a
I
health.
guess the average they're still making money.
yeah, it's like they're making money off like me and you, because we don't cost anything, but they're losing money on the dialysis.
And once you reduce it on the sicker, then you're making more money as an insurance company. Even if you reduce premiums, you're not going to reduce it to cover that total 50%. If you reduce it 40%, you keep that 10%, kind of incentivizing you as a business to continue playing. But overall, you need to show these numbers on an economic standpoint to the insurance company to start doing it.
That's a good question. Any other thoughts on that? Like, if any of you guys have worked with insurers?
Well, there's just also the point that Medicare and Medicaid, our politicians are always looking to reduce the cost. So if there's ways to do that, that's still dignified and promotes health, that's beneficial to the whole country.
Yeah, absolutely.
I just think it's really interesting right now how Medicare works in regards to like nutrition therapies. We were learning in one of my classes that so dietitians or nutrition professionals do medical nutrition therapy to help manage diabetes and other metabolic conditions. But to get reimbursed or to be covered under Medicare, they have to actually have diabetes or have renal disease already.
Yeah.
So if you're pre-diabetic, you're not eligible. And then once you are eligible, you only have 3 hours, or a max of 3 hours for the whole year. So think of it like the patient can see the dietitian every 4 months, or the dietitian, the way my professor was saying, they can split it up into 30-minute sessions. So you get more sessions throughout the year. And then after that first year, it gets reduced to 2 hours. So again, the amount of exposure that they get is very limited under right now the current policies.
And that's probably, that's very interesting, and I wonder if it's because of how effective is nutritional counseling on its own to influence behavior. If there's no cost there's no reduction of cost or research that proves that within Medicare, then they're not gonna cover it. However, if they see financial, if private insurers pick it up first, and then you see these financial implications, Medicare will, I'm not American, I don't know the US healthcare system very well, but I trust that there's that good intention that would enable them to cover this because of that.
Yeah.
But you're not gonna see it with just 3 hours a year.
That's what I'm saying, like,
The
they're
problem
not.
is that you're not gonna even be able to show them.
So for example, like
Not enough of an exposure.
So in one of our classes, we do nutrition counseling, and it's about all behavior. And it's like you have to have multiple exposure, or you're not going to actually change it, because there's so much, like, your environment shapes your behavior, and to really get you out of that phase, it just takes so much time. So it's really, that's what I just found so interesting when I heard that, and especially you mentioned like insurance and all that. It's like, wow, like it's kind of like, oh.
Thank you. So then the second one was a 6-month intervention. It gave all meals and snacks, so 100% of daily energy requirements. And this one was both HIV and diabetes. And so I think the caveat with this one is they were able to show, they basically like surveyed people at the beginning before the 6-month intervention and then afterwards. And they were able to show way lower food insecurity. So the percent of patients who said like, I'm struggling to meet my like daily nutritional needs went down from 56% to like 7% or something like that. Lower depressive symptoms, that was statistically significant, and then improved adherence to their entire healthcare regimen. So the percent of people who said, I sometimes trade off food for medication that I'm supposed to be taking, or vice versa, went down significantly. The piece that was not statistically significant was like I don't know if you would call it biomarkers, but like the blood glucose level and like blood pressure and things like that. They were not able to show statistical significance on that, but it was only 6 months, so.
Were these like full, like all of your days?
Yeah, 100% like 3 meals a day and snacks. And then the MANA study, so this is the organization I mentioned earlier that operates in Pennsylvania, worked with Geisinger and compared health insurance claims for chronically ill Medicaid patients who received 6 months of medically tailored meals with a control group. This one had by far the most significant results. $12,000 less per month in medical expenses, so pretty significant. And again, this was not randomly assigned, but kind of gives an indication of if we were to do more research, the kind of results we might be able to get.
So we're seeing that there are like kind of good results, but our question to you guys now is, why do you think there are possible reasons this has not taken off?
Can I just ask a clarifying question? First of all, I really think those are interesting papers that you picked. I was curious from your reading of the literature, is this an all or nothing type of thing? Because those examples are all like every meal and all the snacks versus none of it. Is there any halfway, or is it just the kind of gold standard, which is everything or nothing?
Yeah, that's a great question.
I don't know if you saw something that looking at dose response or something, a paper like that.
So the way we defined food as medicine was kind of like you get medically tailored meals. You get all of it.
100%.
But
not like just medically tailored dinner and your own food, other meals or something. There's no other models like that.
I think actually community servings might do that. So
I was gonna say, so I helped out in a study called Food as Medicine.
Oh yeah.
So it's really interesting because the way they the way it's the physician and the dietitian were pretty much catering a whole menu and a whole diet plan for all their patients. So they focused more with youth that were pre-diabetic. And their approach for food as medicine was whole grains and focusing more on vegetables and fruits. So the way they would bring in the children for the initial biomarkers, like to look at their blood glucose, and then through the months, they would do diet recalls, 24 hours, to see, hey, are you adhering to this diet? And then they would come in again, get more like their lipid panels, again, blood glucose, and they saw that some of the kids actually got out of prediabetes. Like, it was really interesting. And yeah.
So it sounds like it's a whole range of stuff that's called food as medicine.
Yeah.
And you're picking the ones that are the most
comprehensive. Yeah. And then sorry, go ahead. Okay. Do you want to mention? I know you're not the expert, but we had talked with the Women in Food Systems about ESF and the results that they were able to have, which is just fruits and vegetables.
Right. So this isn't really food as medicine, like you said, but ESF, I believe they give out, and some of you might know more than I do, but vouchers for fruits and vegetables, and they did a study, Hillary Seligman, who founded the organization, and found that there was significant cost savings with emergency room visits for diabetes-related complications.
And that's just fruits and vegetables. Yeah. Anything else before we move to this question? Okay.
So what do you?
I like this idea, but I guess it just seems like a little like unrealistic to like always just supply people with like every single meal. When like one, maybe that's not sustainable and actually making like structural changes, and two, when people are like struggling to get any type of food in the country, or like we have just such little funding for SNAP and WIC and those things, so I don't know, I feel like there's just a disconnect there. If it is that like you get every single meal, like full meals, for free mostly.
The way we thought about it is like, is this a Band-Aid approach? Like you're basically saying like you're extremely sick, so now we're going to like
or like how long can it last? Like how long can these nonprofits supply? Like how long do these it is for life that the patients get it, or like I don't know, full meals, and also like these other governmental programs are struggling to get food to people seems unrealistic.
Yeah, for sure. Seems like maybe if there was a component, like if it was going to happen, like if there was a component of it that also like provided the recipe for the meal, like each time they get the meal, because there was the one article that you posted where one of the recipients said like, now I'm using like chili powder and garlic and something else and like everything I'm cooking. So like he learned how to like you know, prepare his own meals like more healthfully. So
Can I put it on as like learned behavior rather than?
oh yeah, that sounds much better.
I put recipe, but I'm still.
And getting food to people is very logistically challenging. So either you do Meals on Wheels and take it to them directly, or there's adherence issues where if someone has to come into the clinic to get a food box every month, then now they have to use their own resources to get there.
People also are subject to the menu that is provided. Could be lack of choice. You could make some choice.
are you thinking about that from like a like you get sick of it, or like it's not culturally appropriate?
Both. More so, you know, it's not what you want it
It was off the learned behavior that once they get off it, can you provide a way for them to actually have similar meals afterwards? Because that's what you essentially want.
I was also thinking like you're providing meals, but you can't like force it down their throats. But then I was thinking like, I mean, that's kind of the same as pills. Like you can prescribe it to them, but you can't forcibly make them take it. So I kind of negated my own. But now that you mentioned it anyway.
Just throw it out there.
I think another thing is that insurance companies are really good at insurance, but they're not really good at making food. So they may not understand what goes into it and why they should branch out.
Okay, so we've considered 3 key propulsion considerations. First, the shift to value-based medicine could increase the value of programs such as this, given that we're looking at total outcome and kind of the total health of our patients. This reduces cost, increases health, and provides better care to our patients. So it could be a key ingredient in healthcare in the future. The second is legislative change. We see that there are more benefits being allowed under Medicare, aiming to improve healthcare, but also this bipartisan kind of agreement that food is medicine, and it could help in reducing healthcare costs and improving health outcomes. And also provider education.
So this one, it actually kind of gets to the last point about insurance companies not being experts in nutrition. I mean, some of you are providers or soon to be providers. My understanding is that nutrition education in medical school is not particularly robust. So
what is it, like half a day out of 4 years, maybe 3 hours?
We rely heavily on our nutritionists.
Right.
Gratefully.
So, and so as long as providers are aware that they don't know that much and refer to nutritionists, that's great. If not, I think it's partly awareness, and it's partly do we need better education in med school for providers.
For a second, this just reminded me of how little in medical school is taught about natural childbirth, for example. This is completely off topic. Completely off topic, but this is exactly the same. And this is this is undergrad to go women's psychology class, and it's all about how it's like you teach people how to do C-sections. You don't teach them how to do natural births, and that's what doctors do, and that's kind of the U.S. kind of. Anyways, back to nutrition.
So if you want to go have a natural childbirth in a hospital, there's a big flag that's put on your file, like, watch out for this one.
Hippie.
Yeah. Exactly.
Okay. So what are your concerns about this kind of approach? Now we have reasons for it not taking off, but what are your kind of considerations going forward? Again, it might overlap here, but why do you think this is not going to work?
I don't think physicians should be the only one giving or providing the meals or the order for the meals, just because I feel like there's a general mistrust of physicians a lot of the time, especially among certain communities.
Oh yeah. I think it's very paternalistic, which at different areas of medicine have been more paternalistic than others. But I think now we're moving more towards patient autonomy, collaboration, shared decision making. So I think that kind of takes away a little bit of that from the individual.
Yeah. Eat this.
Yeah.
And only this for the next 6 months or 19 months.
Yeah.
Oh, for me, it was more like sustainability. Like you mentioned the whole Band-Aid thing. But like through this process or all these programs, are we also providing the behavior change too? And that will lead to, I think, more sustainability, because then on their own, they can develop their own meals, and if they have that education and motivation to change.
So within the sustainability kind of framework, is the current situation sustainable? Is the current kind of projection of our U.S. population sustainable from a healthcare cost perspective, from a health perspective? And that to me is the answer is no. So, and I'm just like playing devil's advocate, but so like with sustainability, nothing now is sustainable. So I'm like, if there's an approach that could get us another 10 years of a little bit more improved health, I personally am for it. But that's a key consideration about like situations such.
It's labor intensive. I think coordinating and identifying patients to getting it delivered, and then probably also like the HIPAA stuff, probably protecting people's information, connecting them to deliveries. There's a lot of coordination going on.
There's also food safety issues.
Well, that was relating to one thing I was thinking about, the scalability, because all these programs that have worked have been kind of smaller, highly controlled, and anytime you try and scale it, even when we think about hospital food, right, and we try to do it en masse, that's super food safe, but then the quality just goes down. So maintaining the quality is going to be a challenge to make it palatable, especially if you're going to force them to eat it, or Amy's going to force them to eat it.
Oh, I was gonna say, it doesn't, referring to that, the Band-Aid conversation we were having earlier, it doesn't address the root causes. I don't think like the more upstream causes of ill health, which I guess we're gonna say is poor nutrition in this context of food as medicine. And it's also shifting the cost to people who didn't cause the problem. Why should it be health insurers who are paying for this intervention, or whoever is gonna decide to pay for this thing? Why isn't it, the fast food companies and the soda companies and everybody else?
So I'm thinking healthy cities. I don't know if anybody has hit the cuts, but anyway. So one thing that that we talk about is.
I had stream of consciousness.
But kind of what we talk about is the root of all these causes is kind of ingrained racism in the U.S. population and structural racism, and that's that. If we're really looking to, and then the insurance company shouldn't be paying. It's all the white people in America. But like if you look at it, but if that's the kind of so this is really a conversation and a hard conversation to have is how far do we go back to kind of where are the real causes of these problems? So, okay.
Okay, so these are some other concerns that we had. One is inducement. So this was a hot topic in the for-profit healthcare world I was in this summer, which is if you are providing a benefit to patients that your competitor is not, are you inducing them to use your services because of this benefit that you're offering? So like DaVita, for example, can't say, hey, when you become a patient of ours, we're going to give you a $100 gift card that you can use at the grocery store because we know that your food insecure and diet is now really important and you're on dialysis. Which makes sense, right? You don't want to have DaVita saying like, hey, come be my patient for this $100 gift card, even if it's coming from a good place of like wanting to improve nutrition. So
health insurance companies, you're saying, can't do that?
A providers
can't do that.
For-profit providers can't do that. There was like a ton of concern about that. So like with Lyft and Uber getting into transportation, for example, like that, I guess the way I would frame it is like government policy kind of like sets a lot of what then for-profit can do. So DaVita can't say like, I'll pay for your transportation because then it looks like, well, you're giving rides so that people like come to DaVita. But if Medicare says we're going to cover transportation, then health insurance, commercial insurance can say like, okay, that's going to be a benefit in our plans as well. Okay. But like DaVita can't take that upon themselves. Okay. Yeah. So that was a huge concern over the summer for me, was like, we can refer to community resources, but we can't provide the resource ourselves. And then this is pretty poorly worded, but I wrote it so I can say it. So we start with those who have chronic disease. We start with these patients who are really, really expensive, but then we may someday move up the chain and say, like, we're not just going to treat people who have chronic kidney disease, we're gonna do dialysis, or we're gonna do diabetes too. And then we say, okay, we're gonna do pre-diabetes too. Well, so then, like,
how far do you go?
yeah, like, does the healthcare system control all the food that we eat, and is that a system that we want to be a part of? How does oversight work? So we talked about this a little bit. Do providers know enough about nutrition to be able to prescribe medically tailored meals? So in some of these, this would apply to like the Wholesome Wave organization. Like they're working directly with providers. Is a provider actually knowledgeable enough to be able to write a food prescription to say like, go eat more fruits and veggies? Will this work everywhere in the country? Why or why not? So far it's been, as Professor mentioned, pretty geographically concentrated. So is it something that could scale? And then, is it a Band-Aid approach? What solutions would you prefer to see? We definitely prefer that.
So, this brings us to our group exercise. So we want you guys to spend the next 10 minutes, wait, what's the time?
We need just a few minutes at the end for them to do the evaluation. So
Okay.
we just need to stop at
8 minutes, 5 minutes, to draw the potential food as medicine program. So we've talked about the issues, the stakeholders, our concerns. So we kind of have a working mindset of what are these issues. So let's sit together and draw out a plan. See, 4 groups.